I'm honored to introduce today's distinguished speaker, Dr. Angela Hogan, professor of pediatrics at the Macon and John Brock Virginia Health Sciences at Old Dominion University and Eastern Virginia Medical School. She serves in the Division of Allergy and Immunology at the Children's Hospital of the King's Daughters and is a senior partner at the Children's Specialty Group. Dr. Hogan is a perfect example of the tripartite mission of academic medicine. She excels in clinical care, education, and research. She completed her medical degree and pediatric residency at the University of Louisville, followed by a fellowship training in allergy and immunology at the University of Virginia, and a fellowship in clinical and laboratory immunology at VCU, which was MCV back then. She also completed a 4-year postdoctoral study in immunology, reflecting her deep commitment to advancing the science behind her field. She is a fellow of the American College of Allergy, Asthma, and Immunology and the American Academy of Pediatrics. She currently chairs the American College of Allergy, Asthma, and Immunology's Asthma Committee and serves on the planning group for the American Academy of Pediatrics National Conference and Exhibition. Her contributions were nationally recognized when she received the 2023 Jerome Glaser Distinguished Service Award from the American Academy of Pediatrics. Dr. Hogan is a passionate educator with more than 70 national invited presentations. She has led community outreach efforts in asthma and food allergy education for nearly 2 decades and currently serves as the medical director for several food allergy sport organizations in the Fair Neighborhoods Initiative in Hampton Roads. She has also been named a top doc by Coastal Virginia Magazine every year for the last 20 years. Please join me in welcoming Dr. Hogan.
Yay. Hi, everybody. So I probably will stand here and kind of talk a little bit more, although we got a few less people over here. So if I don't look your way quite as much, it's not anything personal. So I'll kind of talk at you this way. And I think whoever's out in virtual land, thank you all for coming. I'm really excited to have this opportunity. As you know, in allergy and immunology, we're a conjoined board. So we actually are board certified to see both adults and children. Although my area of expertise, I see about 95% children because CHKD doesn't love it when I see a lot of adults. But my oldest patient is actually 85. So I do have some long-term experience with patients with allergies that are adults. So what I want to talk today about is asthma because that's something I'm very excited about. And it's actually a good time to talk about asthma because we are actually, this month is National Asthma and Allergy Month. And earlier this month, we actually had the World Asthma Day. So I will cover that for you. What I want to talk about today is some practical approaches to your patients who have asthma, specifically focusing on Gina. Gina feels like she's my best friend, but probably all of you know that it's the global initiative for asthma. So that's what we're going to talk about. I do have one disclosure. I am on the Speakers Bureau for ARS, but they produce an epinephrine product that has nothing to do with our asthma today. So as I mentioned, on May 6th, it was World Asthma Day. This happens every year. When May 6th happens, GINA drops their newest guidelines for asthma. So 2025 updated asthma guidelines came out that particular day. And as you know, GINA tries very hard to process whatever studies have been done and what new information has happened. And they try to incorporate that in yearly updates, as opposed to our country, where we have our National Heart and Lung NHLBI guidelines, which don't get updated very often. And as you know, the most recent update is 2020, and we are still just very sadly out of date from those guidelines, but we will show what correlations there are. What I want to talk about today are some things that just good information, perspectives on asthma. Then I want to review for you what are the newest updates in GINA in terms of using AIR and SMART and MART therapy. And then we're going to talk about how you can implement that in patients that are in your practice. So we'll start with a definition. What is asthma? And I think asthma, we all know this, has 3 main components that we need to think about. And probably the most important component is inflammation. And that's an ongoing process if we're not treating asthma appropriately. We also know that there's increased mucus production, and we know that there's this bronchial hyperresponsiveness. The lungs are trigger happy. If you provoke them in a certain way, they want to be twitchy, and that's what bronchial hyperresponsiveness. And all of these are associated with reversible airway obstruction, and that's important. That distinguishes it from other forms of adult respiratory diseases. So, and asthma isn't just one disease. And so, because of that, one size doesn't fit all. We know that there are different risk factors when we think about the development of asthma. There's onset of asthma in childhood, there's onset of asthma in adulthood. We know that there are clearly different triggers. We know that people don't always have the same symptom. As you know, there are people that just cough, they don't ever wheeze. So we have cough type asthma in patients. Clearly, we all know there's differences in severity. That's why we have different management and step levels based on severity. We know that not everybody responds the same way to therapies. And we know that comorbid conditions, especially in adults, significantly impact whether they have reflux, whether they have chronic sinus disease, whether they have nasal polyps, whether they have obesity. All of those things can impact how we manage asthma. And we have to take that into account when we're thinking about asthma. So why am I so passionate about asthma? Because lots of people have asthma. It's a very prevalent entity. And if we look across the United States, in this particular slide, as you can see, that is from the CDC, that asthma is disproportionately affects certain populations. And unfortunately, those with lower socioeconomic status have more impact from their asthma. They tend to have more severity. We also know that there's a disproportionate amount of asthmatics based on race and ethnicity. And in this particular slide, you can see here that according to the most recent national survey, about 10.3 of Black individuals actually have a diagnosis of asthma. And you can see the prevalence there. It's a little bit higher in females, and it's a little bit higher in adults. We know that asthma attacks actually have kind of plateaued out over the last 20 years or so, and that's very encouraging. We know that for adults, asthma attacks declined actually from 2001, where we saw about 50% annual rate of asthma attacks, and we're down to around 40%. So those are good strides. And I think much of that is because medications are becoming more available for understanding asthma better. And we have this thing called biologics, which I am not going to preach on today, but they have made a big impact on our ability to reduce asthma exacerbations. And as you can see here on this graph, let's see, does the pointer work for me? As you can, there it is on this graph, you can see that we are seeing a decrease in the percentage and almost kind of a plateau, both same for children and adults. And what we do know is that people with asthma access the healthcare system a ton. In fact, in 2023, there were 1,700,000 emergency room visits for asthma alone. We know that it accounts for roughly 500,000 hospitalizations, which is a big impact socioeconomically also on our healthcare system. And sadly, when you have an acute asthma exacerbation, we're still 20 years into the same basic therapies, with the mainstay being oral steroids and bronchodilators. And while we are seeing a decrease in the number of emergency room visits over the last 2 decades, there's still a whole lot of emergency room visits for asthma attacks. And unfortunately, asthma does still cause deaths. We know that on average, in any one day, 11 people in the US die from their asthma. And while we have seen some decline in the rate of asthma deaths, there is still many more than we would like to see. The rate of asthma deaths are nearly 3 times as prevalent for Black individuals. And we also know that adults are much more likely to die from their asthma than children. And part of that may be understanding asthma. Some of it may be the medicines that we are using to prescribe for those asthmatics, which we'll talk about in just a moment. The highest death rate is in individuals with asthma who are over 65. So, and asthma costs a lot of money to the healthcare system. The overall prevalence of adult asthma is roughly about 9%. 60% of adults with asthma actually have uncontrolled asthma. That has nothing to do with severity. It's just that we are, or they're not, or whatever. The system is not helping to address all the inflammation and the symptoms that we see with asthma. And we know that people with uncontrolled asthma cost the most money to the healthcare system. And researchers estimate that from 2019 to 2038, that the cost of uncontrolled asthma will be about $964 billion to the healthcare system. So it behooves us to want to help control asthmatics, at least in terms of we don't have enough healthcare to go around for everyone. Socioeconomic costs yearly are about $53 billion. So, what I hope that I have impressed upon you is that it costs a lot of money and we have a lot of room for improvement, and a large population are affected by adult asthma. So, what is the pathophysiology of asthma? Well, we mentioned it already, that inflammation is a huge part of it. According to GINA 2025, it is this chronic illness that has inflammation. The signs and symptoms we all know are predominantly wheezing and shortness of breath, also chest tightness. Don't ever underestimate cough. Cough is the most common symptom in asthma, and it usually presents long before they go on to wheeze. We also know that there is airway obstruction, and there are lots of different phenotypes of asthma. Phenotypes are those patterns or things that we see. And so I thought I would just mention some of the most common phenotypes that we see in adult asthma and childhood. In childhood, mostly what I see, 80% of the asthmatics in childhood are allergic asthmatics. And as you know, in those individuals, the eosinophil is the predominant cell. They're usually triggered either by viral infections or by something they're allergic to. But in the adult picture, we know that there are different cell types that are responsible for those phenotypes. We feel fortunate when they're an eosinophilic driven pattern because most of our biologics are geared towards the eosinophil, but there are individuals who have mixed patterns. There are also individuals who have neutrophilic. We also see a lot of exercise-induced asthma in both adults and kids. There's also the aspirin exacerbated syndrome that we see where the cell type there is also eosinophilic. And this is just kind of a good chart. And I'll make my slides available if you all want to have a PDF of them, if you want to come back to them, or if any of these tables are helpful, that you can look back. But this sort of gives you, again, the overview that all asthma is not exactly the same. So how do we diagnose asthma? Well, this could be an hour-long lecture in and of itself. However, I wanted to cover lots of things. So in simplicity, it is the classic symptoms and signs that we see with asthma, and spirometry can be very helpful. And you all are lucky, most adults can get spirometry. In my pediatric office, we struggle very mightily to get kids to be able to do spirometry and blow out long enough. But what we know is that basically it's airway obstruction. And as you can see on this particular slide, which if I were to point the right button, which I did just now, as you remember from spirometry, we used to say that it was a 12% change or 200 ml change, reversibility demonstrated with bronchodilators. But about 2 years ago, the ATS actually lowered that and said 10% change is all we need to do the diagnosis of asthma. And it doesn't necessarily mean that the one time that you do the test, and if they're normal, that they don't have asthma, it may be a good time when they don't have inflammation. So you might have to do multiple spirometry or look to see what their response is long-term to treatment in order to know whether or not they have asthma. The other thing, too, is you have to rule out other causes before you say that they, in fact, have asthma. We also use something called pheno. I don't know how much you all have experience or exposure with that. It's becoming more mainstream in more and more offices and less a research tool. Pheno, as you know, is exhaled nitric oxide. And what it is it's a marker of how much inflammation is in the airway. And you have to do the pheno before you actually do the spirometry test. But it can be a very good tool in letting you know that they have inflammation still in their airway. I like to call it a lie detector test. So I have lots of patients who say, oh, yes, I take my medicine every day. And then you look at the refill rate and you're like, not quite so good. And then we go and do a pheno and the pheno is 90. And I'm like, how long has it been since you had your medicine? And many times they'll be like, oh, you found me out. So I like to use it as a tool mostly for poor adherence, but sometimes I'll also use it as a tool to help me decide if I'm going to be putting someone on a biologic, what kind of inflammation and how much is there. And it can also help me measure my responses to therapy. So it is a helpful tool, and I think it's going to become more and more mainstream as we start to get reimbursement for it. I think it will move more and more into our offices. So what are the goals of asthma therapy? Well, this is a very kind of, even our national guidelines say, basically what we want is we want the patients to have a good lifestyle, to be able to do what they want to do with few asthma symptoms. We want to help control the asthma inflammation, and we want to make sure that their lungs aren't getting worse over time. And then on top of that, we want to make sure whatever medicines we give them don't have a lot of side effects so that they are happy and healthy and the world is a better place. And ideally, we would also like for them not to have asthma attacks. And those are kind of all the things that are rolled into what Gina says are our goals. And we have to take the patient's opinion into it, and we have to know their lifestyle, and also it's helpful to know what their phenotype is. So those are your goals for asthma management. And now I would like to say to you that I think it's very important to know that in general, people's concept of asthma is very wrong. The average person views asthma as an episodic event, like, oh, I had an asthma attack, and then 2 months from now, I don't have any more asthma. And we see that based on people taking their controller medicine over and over again. You know, they haven't seen you for 3 months, they feel great. What's the first thing that goes away is their asthma controller medicine. So we really need to re-educate people that asthma is not an episodic event, that just because all we see is the tip of the iceberg doesn't mean that there isn't a whole lot of other stuff underneath the surface, like inflammation, that we need to address. And Gina says that much of this asthma morbidity and mortality that we see is preventable if we can re-educate our patients to the importance of the right therapy at the right time. So what do we know in 2025? We know that exacerbations still happen, and they are a significant cause of morbidity and also asthma costs. We know that despite our recent understanding and advances in asthma therapy, no one size fits all. So we need to have different ways to think about asthma. We know that compliance is an issue with every patient over and over again. But I think as internists, you see that with everything, right? With their blood pressure medicine and with their diabetes medicine. We need to keep trying to push people to do what we say, which can be vary. And the first thing that we know is that asthma does have symptoms, and all patients need a reliever therapy. So what we know is that short-acting beta agonists like albuterol have been our first-line asthma therapy for almost 50 years. But what do? They make you feel better, but they don't treat inflammation. And that's a hard thing for the patients because they're like, oh, I took my albuterol, I felt a lot better, I guess my asthma is gone. But again, all we did was sort of treat the surface, and we didn't treat the underlying process. And we do know that in individuals who use a lot of short-acting beta agonists, that they access the healthcare system much, much more. And we know that that makes them at greater risk for a worse asthma attack. And roughly 50% of all patients who are experiencing asthma in general, even in spite of good therapy, 50% of them may still have an asthma attack every year. So when we're even really doing a good job, they're still susceptible, the wrong virus, the wrong pollen season, plus the wrong virus, and they still may have an asthma flare. So we want to try to reduce that risk. But even when we're doing well, we still see asthma attacks happen. So how many of you have seen this commercial? Anybody? Thank you. One person. In pediatrics, everybody has seen this commercial because there's a dinosaur there. And that dinosaur his name is Walter, in case you care at all. And he is, in fact, a T-Rex, which is what all my patients ask me, what kind of a dinosaur is he? In this particular commercial, what you can see is this dinosaur, and he is wearing an albuterol chained around his neck. And in the commercial, he stalks this particular guy. He follows him to the elevator. He follows him down the street. He follows him into the doctor's office. And at the end of it, they put him in this yellow taxi and they wave goodbye and they played that really good song, Goodbye to You. And the long and the short of it, I really like about it, and I use it with my patients, is albuterol is dinosaur medicine. There's really much better things these days that we can treat asthma with than this particular dinosaur medicine. And it is such a strong statement from GINA, both 24 and GINA 25, is that albuterol should never, ever, ever be used alone in any patient who you think has asthma. And so that's what I'm going to convince you of today, is that you shouldn't be prescribing albuterol in isolation to patients with asthma. And Walter is going to help us do that. So again, what do we know? Short-acting beta agonists treat the symptoms, but not the disease. And we know that even in patients where you think, well, they have really mild disease, and I'm just going to give them albuterol because they just need it episodically, those patients can still experience sadly have death from their asthma. In fact, 27% of asthma deaths are in patients who had mild, intermittent, or mild persistent disease. That's a quarter of asthma deaths in people we thought had mild disease. We know that you can't predict when the asthma trigger is going to happen. You know, you could walk to clinic right now today and someone blow in your face and they've got the flu or rhinovirus or who knows what's going around. As you know, we're not in control of pollution. We're not in control of smog. We're not in control of all the beautiful allergen levels that are out there, although it's job security for me. But we have had a wonderful spring with tons and tons of pollen. We can't really affect and change that for our patients very easily. And what do? We give them oral steroids because that's the easiest way to bring them back. What I want to remind you is that GINA says lifetime oral steroids are additive. So if you think about those people that had oral steroids when they were a kid 15 times, and now they're an adult and they don't take their medicine very well, and we're now giving them more steroids, even 4 to 5 lifetime courses of oral steroids significantly increases your risk for osteoporosis. In kids, it affects their growth. It also increases their risk for diabetes, for cataracts, for heart disease, for pneumonia. The additive effect of steroids is not what we ultimately want to be using to help that's oral steroids, to help manage our patients. And we need to think about that. How many times has this patient had steroids in their life? And is there a better way? And so what I actually do with my patients is I turn over a piece of paper and I draw the biggest circle that I can draw on a piece of paper. And then I draw a little polka dot off on the side. And I say, this big giant circle is one single dose of dexamethasone in terms of how your body sees it. And this little polka dot over here is 2 puffs twice a day of your regular controller medicine for a year. Which circle is bigger? And they'll be like, oh, well, this circle down here is very small. And I'm like, yes, that's much better for your body to get a lot less steroids. And in pediatrics, we have a lot of really steroid phobic families. And that visual really impacts them. And it really is that big of a difference. One single dose of Dex versus a small dose of controller every day really is a lot less steroid. And then I want to tell you that unopposed albuterol is actually very dangerous because if you use a short-acting beta agonist, even 1 to 2 weeks using it twice a day, you downregulate your beta-2 receptors, and it doesn't work as well at the end of that week as it did at the beginning of the week. And so what do? You use more, and then it works even less. And in order to reset your response to albuterol, you've got to get oral steroids or a longer course of inhaled steroids. And what we know is that more and more and more short-acting beta agonists can lead to worse outcomes and a more severe exacerbation. And there's this thing over the counter, I don't know how many of you all have seen Primatene Mist, but I would absolutely like to yank that from the shelves and throw it away and put a disclaimer every time. It's even less beta specific than albuterol. It's extremely dangerous. And I'm on the Asthma Morbidity and Mortality Committee for CHKD, and we review all of the asthma deaths in kids. And what do I see over and over and over again? A child who's had 15 albuterols prescribed in the last year because whoever the next doctor was just kept refilling it. Or I see Primatene Mist used in teenagers, and literally there was one girl recently who died, who the Primatene Mist was beside her. And so we need to make an ask. First of all, are you using over-the-counter short-acting beta agonists? And we need to get them out of the system if you have any particular advocacy opportunities. So as I mentioned, mild asthma doesn't necessarily mean safe. So I want you to think again about your short-acting beta agonists. And we know that actually in patients who have recently had an asthma flare, that most of them aren't taking their maintenance medications. And we also know that there are safer alternatives to albuterol alone. So let's talk a little bit about that. So according to GINA 2025, the safest and most effective approach to asthma treatment in adolescents and adults usually uses a combination of an inhaled steroid, specifically formoterol, uses an inhaled steroid and formoterol across all asthma severity levels. So let's see what that looks like. So what we're going to talk about next is what we call SMART therapy. And SMART therapy is also called MART therapy, and I'll go over that with you in just a second. But it uses specifically formoterol as your bronchodilator. And formoterol is the only bronchodilator that can be used when we are thinking about doing SMART or MART therapy. So basically what we're going to move towards thinking is using one inhaler that is used both as maintenance and reliever therapy. And then when you're sick, you increase it up. And when you're well, you dial it back down. And again, there are two products in this country that have formoterol. One of them is packaged with budesonide. That would be your Symbicort or your Brana. The other one is mometasone formoterol, and that would be your brand name Dulera. And what we know that the most important part is the formoterol. So GINA has some terminology. Maybe these are terms you've used sometimes. When you're using it as a rescue only, we call it AIR, which stands for anti-inflammatory reliever. And if you're using it for both maintenance and reliever, we used to call it SMART, and now GINA likes to call it MART, but in this country, we use them interchangeably. I like to call it SMART because I can use a little play on words like, and this is the really smart way for us to do asthma medicine, and it seems to be catchier to me. But they're both basically interchangeable, SMART or MART, and that means the everyday asthma medicine that we're going to do. And this is the table that probably you all have seen many, many times. And this is the 2025 update, which basically has two tracks. Track one is the preferred track that we would use to manage adults with asthma. And track two is the alternative track if you can't get track one paid for or patients are not able to tolerate it. And what I want you to see first here is that the reliever medicine is an ICS formoterol. And then if you have patients who have mild, persistent, or mild intermittent, step one and step two, that inhaler is used when needed, and we'll go over that in 1 second. And then as they have increasing disease and you step up, then you start adding more puffs, and you still use it also as a reliever therapy. And we'll go over that in pretty much detail here in just a second. So where do you start with it? Well, they have nice tables in GINA where you start, but I think they're pretty arbitrary. I sort of see where they've been, how much they've had, where does their spirometry look, and I sort of pick the doses based on that. But there is a system that sort of says if they're not doing well, let's use higher dose. And if they're doing better, we can use a little bit less number of puffs. And how well does it work? Well, this slide to me is very impressive. So in this particular slide, it's the summary of about 10,000 patients. And what it did was compare using the ICS formoterol against albuterol or SABA alone. And in those patients who had mild intermittent disease, there was a 55% reduction in the amount of oral steroids that they needed. And there was a 65% reduction in the number of times they were either hospitalized or had to go to the emergency room based on the Cochrane analysis that was done, the Cochrane database and systemic review. So clearly, we know that combination ICS formoterol has a big impact when it is compared to short-acting beta agonists alone. And we also, if you compared to someone who's on daily medication with a short-acting beta agonist, versus the ICS formoterol. What we also see in that particular group, and that's using the ICS formoterol as needed, there is still a 20% reduction in oral steroid needs and also a 37% reduction in emergency room and hospitalization. So this particular product does work better. And so what we usually say to patients is, it's nice, you just have one inhaler, you don't have to decide which one you need, and we know that this works better. In the studies that were done deciding that MART or SMART was better, all of those studies for Gina were actually done with budesonide formoterol and not mometasone formoterol. They don't have mometasone formoterol in Europe. But by extrapolation in this country, most of us will also use the mometasone formoterol product. Dulera versus Symbicort Breyna. You said I was allowed to say the names. So anyway, all right. So, and this is, again, what it would look like. And what I want to show you is that when we step up to step 3 and step 4, is there science to show also that this way works better than our traditional way of treating with a different controller medicine and a short-acting beta agonist? And that is also true. You can see here in the first graph, when we compare it with the same dose of an ICS LABA that uses a short-acting beta agonist versus the MART therapy, that there is a favored response, 32% reduced risk of exacerbations. When we compare it to even someone who's on a higher dose of an ICS LABA compared to MART, there is a 23% reduction in the number of exacerbations. And when you look to see in this graph here, from time to onset of symptoms, that it clearly does favor using the SMART or MART method compared to traditional ways that we have been treating asthma. And then also there's a lot of emphasis and focus on eosinophils. And what we know in that patients who are on MART, this particular combination is both more effective in people who have eosinophilic asthma and non-eosinophilic asthma. But it is particularly more helpful in those who do have a higher level of blood eosinophils. So it looks like it works better than our old-fashioned way. If we look at our national asthma guidelines, you can see that our national asthma guidelines do say, at least by step 3 or step 4, we should be considering MART already. The biggest difference in our national asthma guidelines here from 5 years ago now is that on step 1, they are touting short-acting beta agonists alone, and Gina would say, mistake, don't do that. So hopefully soon our national guidelines will update again, but that's anybody's guess if you ask me. So what do you do if you can't get the inhaler paid for? I don't know how many times you all are having to do prior authorizations. There's a whole song and dance that we have to do in our office. Some insurance companies want brands, some insurance companies want generic, some insurance companies want the GoodRx coupon, some insurance companies want 15 pages of notes for me to document why, in fact, science says MART is better, and sometimes I just can't win. And then there are patients who are like, but I've always been on this. I don't want to change to new and improved. So it can be very challenging. So let's go over track 2, which is what you need to do if you can't do traditional SMART or MART. So again, the first thing that I would say is that you should know that if you're giving them multiple inhalers, there's multiple different techniques for some of those inhalers. There's dry powdered inhalers. There's some that are round shaped. There's some that are click open and suck. There are some that are HFA. In pediatrics, it's easy. We give everybody a spacer if it's an HFA, and we teach them. In adults, especially the older and older they get, it's really challenging sometimes for them to be coordinated enough to time it right and get the puff in. And I'm sure all of you have seen that old House TV show where the woman says her inhaler isn't working well, and he says, well, show me how it works. And she's squirting it to both sides of her chin and not even putting it in her mouth. And people forget how to use their inhalers. So each time you're seeing that asthmatic in follow-up, you should probably be reviewing whose inhaler did you get and do you know how to use it. And when we introduce multiple different inhalers, then we run the risk that they're going to have difficulty with those. And then again, they're going to say, well, this one makes me feel better. So they might keep reaching for the short-acting beta agonist instead of the controller. But sometimes we don't have any control and we have to do track 2. So what does track 2 look like? Track 2 says that we step up based on the amount of steroid that they need to control them. And that's pretty obvious. And then when they have more severe, step 5, we certainly should be thinking about referral at that. But one of the things that step 2 has here that I want to mention is an alternative to just using albuterol alone. And that has come on the market, and that's an albuterol that also has an inhaled steroid in it. So if they are having to use a short-acting beta agonist, they get that little bit of steroid. Not only do they feel better, but the steroid helps chase away the reason why they needed that albuterol in the first place. And that may be a much more safe product. This past week at the ATS meeting, there was a study that was presented that looked at the difference just with the controller, the rescue inhaler alone, steroid plus the albuterol versus just the albuterol alone. And there was a 2-to-1 difference in the number of exacerbations when patients were given a combination rescue inhaler instead of just albuterol alone. So we are going to see more and more of that. So what am I talking about? There was a product that was approved in January of 2023 that has both albuterol and budesonide in it. There's only one so far in this country, but we may see more and more of that. This is under the name of AirSupra, if you have seen that particular inhaler. It's only approved at this moment for 18 and up, although there are good studies that it probably will move for younger. And basically what it says is that this can be an effective rescue. There is a maximal number of puffs that they think you should have in a particular day, and that's 12 puffs. And so the question is where does that fit into the process and how well has it been studied? And for many patients, I think this may be a good alternative if you can get it paid for, of giving them that instead of albuterol alone, so we don't have the risk of unopposed albuterol. There was a very nice study done that was called the Mandala study that actually took patients that were on a maintenance ICS LABA of either medium dose or an ICS by itself, and they, in fact, gave them either the combination product of both an inhaled steroid and a SABA versus a SABA alone. And it clearly demonstrated in that study that there was a significant improvement in the time to exacerbation. They had less symptoms and it was more effective. There are no head-to-head comparisons of using an ICS LABA, ICS SABA versus MART, but I think those studies will be coming at some point. So I think that if you end up having to do a track 2, we're going to start thinking about probably an ICS SABA if we can get it paid for instead of a SABA alone. But yet all of the evidence and science shows that actually track 1 is preferred, more effective, safer, and reduces the risk for exacerbations. So you should be trying to get track 1 if you can. And there is really good science across the board, many, many studies that show that MART is more effective in terms of reducing exacerbations and better quality of life. So how many puffs do we actually do in adults? And I have created this little table that I often teach from that can be very helpful. So in general, what Gina says, that if you have an asthmatic who is over the age of 12, you should be using the budesonide formoterol product that is 160 micrograms instead of the 80. Because if they need to have rescue, you're going to want to have that extra steroid that will help keep them out of trouble. And so what I usually say in my patients that are mild intermittent or mild persistent, they can take 1 puff as needed. I want to remind you that rescue puffs using MART are just 1 single puff and not 2 like we do with albuterol. 1 puff is all you need to do when you do rescue. Or if they're pre-treating before exercise, it just needs to be 1 puff. I do remind all my patients to shake it up. I remind them that it's like salad dressing and all the good stuff's on the bottom. So you want to make sure that you get it shaken before you go ahead and use that medication. And then you can see here, as you increase in severity of your asthma, or your asthma is not as well controlled, then we increase the number of puffs. And the top dose for most adults who have significant asthma would be 2 inhalations twice a day of the 160 of the budesonide. Or you can see here by extrapolation the doses that are there for the mometasone. Remembering again that Gina did not study mometasone, but in our country we have that available. And you can see we're not using the 200 of mometasone for most adults. We are using the 100 in patients that are over 12. And then there's a maximal number of puffs that we use when they're in their green or yellow zone. And what we usually recommend for adults is that's 12 puffs per day. So if you were an individual who was on 2 puffs twice a day, what I tell my families is if you need extra puffs because it's a bad pollen season or you're having the flu, then you take 1 additional puff whenever you need it. It doesn't have to be every 4 to 6 hours. That's only with albuterol. So if you take a puff and 20 minutes later you feel like you're not better, then take another puff. And you can go all the way up to 12 puffs. You can do that for 2 or 3 days. And that's the beauty of it, is now the patient is in control and they dial up at home when they're having trouble. If they continue to need 12 puffs a day, then they let you know that they're having struggles and needing that many puffs per day. And then they dial back down when they feel like their asthma is under better control. And having that freedom to dial up before they can get an appointment a week later oftentimes will keep them out of the urgent care or the emergency room, because it's just enough steroids, and budesonide and both mometasone can play catch up if we started at the beginning of symptoms. So this is sort of the classic way that I dose. And even if I have an adult asthmatic who's got spirometry with an FEV1 of 115%, I still stay with the 160 and not the 80, because if they need to be chased, the 80 may not be enough to chase them with symptoms, if that makes sense. Yes, no, everyone's still nodding and awake. That's always a good sign. So what role do oral steroids play in asthma? And again, as I mentioned, 4 to 5 lifetime courses of oral steroids can be very dose dependent, increased risk for bad side effects. And we also know that even the short-term side effects, I know that I'm preaching to the choir here. You all could probably teach me much more about the long-term side effects from even prolonged tapers or courses of oral steroids. Suffice to say, we want to try to move away from that as much as possible. And if we optimize asthma therapy, I think we can use much less oral steroids. Gina really emphasizes that all asthma patients should have a written asthma action plan. And hopefully in your EMR, now are you all, what do you use, Cerner, or who do you use, Epic? Does Epic have an asthma action plan in your ability to fill out and auto-populate those? So why don't we talk at some point and we'll work towards that. We have been able to implement in our old-fashioned Cerner system a way to auto-populate those. But let me show you a couple asthma action plans. So in this one here, this is the Virginia Pediatric Asthma Action Plan that I actually am the author of. We update it yearly. We have a committee that comes together and tries to have it available for all the kids in the state. And there are a couple things that are, I think, very helpful. And what you can see here in this action plan is that there's a SMART pathway that we tell people, if you are using one inhaler for both rescue and maintenance, what do you do when you start having problems? And then there's also, if you have traditional albuterol. And the things that I want to point out to you is that in kids who are doing sports, we just do 1 puff pre-treatment or 1 puff when they come back off the playground. And if you are in the red zone and you're on your way to the emergency room, I don't care how many puffs you've already had for the day, it sort of goes out the window. and I say that you can do an additional 6 puffs, one at a time if you need it. If you're on your way to the ER, don't worry like, oh, but I'm already at my 12 puffs. You get a bonus 6 more puffs if you're on your way to the ER. And this is a plan that has been very helpful for our patients, and we spell it out and we go over it very specifically. If you go to the NIH and look for an adult asthma action plan, this is what you're going to get. And to me, there's an awful lot of blanks in there, and you're going to have to write 15 different lines. And so ideally, most people are not going to want to fill this out, but Gina does say they should have an asthma action plan. So this is a better one that I like at the Allergy and Asthma Network. It says a lot more words. It's adapted for SMART or MART. And I think it can be very helpful for you, and you don't have to write as much when you're really busy. So you might look at something like this, or we might try to integrate something into your Epic system. But I do want to, again, point out for you is that you don't have to wait 4 to 6 hours. The maximal dose is 12 unless you're in the red zone. And if you have someone who is on albuterol, so here's what happens when you go to the standard emergency room. They go to the emergency room, they're on MART or SMART, and the ER physician immediately says, what do you mean you don't have albuterol? You're here in the ER, we're going to use albuterol, we're going to bronchodilate you, whatever, and you must go home with albuterol because you don't have albuterol. And then what happens is that you have this great patient that you had on MART, they understood one inhaler, how to dial it up and dial it down, and now they've been given albuterol. So I'm going to challenge you that if you have a patient that leaves from the emergency room and they're on MART, don't send them home with albuterol, okay? Tell them what to do with their MART inhaler if they're sick and how to continue it, because there actually was a recent study that looked at the standard academic center, and 89% of the time when they went to the ER, they went home with albuterol. And then when they follow up, I've got to take it away, and I've got to explain again why I don't want you to have 2 inhalers, and 1 inhaler is so important and the better way to manage them. Use albuterol if they're in the ER, because that's all we got at this moment. We've got to get new medicines there, but don't send them home with albuterol, because you've just defeated your whole point of 1 inhaler, 1 disease that you are trying to treat there. Did that make sort of sense? I think I probably killed the dead horse there and beat it. Okay, so I'm from Kentucky. I'm allowed to talk about horses. So anyway, what are the issues that we see in 2025? Is there's confusion with the guidelines. They're not standardized. Our national guidelines are not updated. And that 2 guidelines don't necessarily agree at this point. The biggest problem, though, is FDA. So, and I have those patients that Google and they read, and after I've sent them home with SMART, they come in and say, I Googled, and this particular medicine is not supposed to be used for a rescue. It is not supposed to be used at all the way that you have said that it's going to be used. And is the FDA ever going to get behind it? I have no clue. And it's an ongoing battle, and all I have to say is, well, the FDA is not as up to date as Gina is, where they actually show, and in Europe, it is absolutely labeled for as needed use, but we're in the United States. So that's going to be an obstacle. If someone is a Googler and does some reading, you're going to have to educate them about why it is important. And it also is not necessarily approved for mild asthma. They say it's used for more moderate asthma, and we've already talked about we're going to use it in the mildest of asthma. So that is going to be a little bit of a struggle for you. And then I always am asked the question, in my particular hospital, if you have asthma, you might go to the pulmonologist. If you have asthma, you might go to the allergist. And in our hospital, there are some pulmonologists who really, they don't believe in SMART. They just don't think that there's enough science or evidence. So we battle a lot back and forth over you should, you shouldn't. And there are lots of providers who don't buy into SMART or MART yet because they've done something exactly the same way for many years and it seems to work. And sometimes they just don't have time, and it takes a lot more time to explain the patient about why we're going to get rid of albuterol when they've been told they were just in the ER that albuterol is the medicine they need, or they've had albuterol all these years and they're told that's the way. So we need to think about different ways that we can impact and make changes for these guidelines. So we need to make sure that we're teaching those medical students that come along in our rotations. We need to make sure that we disseminate the information to new doctors so they're not afraid to carry it on. And it's also helpful to our older colleagues that we sort of slip in occasionally a little Gina and help them understand why this may be a more effective way. Some people think that we should put prompts into the system potentially that will say this is and Lord knows we get enough prompts, right? That may be a better way according to the guidelines might be to treat in this particular way. And then I think potentially we should think about long-term, do we need to audit charts? Do we need to provide positive reinforcement for those patients that are appropriately managing patients in the correct way, which that one's not very popular, but I throw it out there as something to think about. And then we need good educational tools for the patients. So in this particular handout, which you can get at the ACAAI, this is a handout I created for the college that actually can be given to patients that actually says, here's what SMART is and here's why we're doing it. And here's what we want you to do. This is a little bit pediatric centered, but certainly developing these kinds of handouts for your patients can be very helpful so that they can take something back home and read it and understand why SMART is a particularly helpful tool. And then I think we need to explain to the families, we need to give them choices, but it is important that we make sure the simple things are being met, that they have access to the medicines, that they can get them paid for, and that they know how to use them. And sometimes technology can be a very helpful tool. There are apps that are available that they can chart their symptoms or that they took their medications. And I think it's important that we have regular follow-ups for patients with asthma so that we make sure that they still understand and they are still taking their medications. One of the things that was very helpful is there was a price cap that was put on multiple asthma inhalers on June 1st of 2024. And that particular price cap said for many people with their insurance that those inhalers should not be more than $35 a piece. And I have been able to get this for many patients, even patients with TRICARE. We can get MART or SMART medications paid for. We advocated to the state Medicaid for patients who had Medicaid, and we were able to get 3 inhalers per month per child paid for. Because oftentimes if you're on a daily dosing, like 2 puffs twice a day, then you're going to need to have another inhaler for the soccer bag or another inhaler for, I guess, adults. What do adults do? For their pickleball bag, and another inhaler potentially for wherever else they go. Certainly for school-age kids, we need to send one to the school nurse. So we are seeing improvement in terms of how we're getting these inhalers reimbursed. If you're running into a lot of obstacles, my email is angela.hogan@chkd.org. I am happy to tell you what we're doing, how we're maneuvering it. The college and the Academy of Allergy, Asthma, and Immunology are working daily towards advocacy to get these medications covered better. So I think there are still a lot of hurdles for us in 2025. I think we need more awareness and understanding of asthma and SMART or MART or AIR as a best way to treat asthma. I think we need the FDA to wake up and get on board, although I don't know when that'll happen. I think the NHLBI guidelines, once again, need to be updated because they are outdated. I think we need to continue to make sure that patients understand asthma and why their medicines are important. And I think we need better systematic organization to understand how to implement these and overcome the barriers that are in the system. And then obviously we need better professional acceptance, and also we need more research. So, let's get 40,000 patients to the Cochrane review so that people will accept and understand the importance of this way of treating patients. So what I would want you again to remember is that they may need multiple inhalers. Oh, by the way, we almost never, ever, ever see thrush with formoterol and budesonide combination. I don't even really worry about telling them to rinse and spit or gargle or doing any of that stuff. And Gina actually says if you're doing just 1 puff, you don't even need to mention it. So if you start seeing otherwise, I'll be very surprised. But that's really not been an issue. I do want you to think about having an action plan for most of your asthmatics. And in summary, which I think I left 4 minutes for questions, sorry about that. I think you should really think about not giving patients SABAs only because of the risk and so much improved therapy. Air Smart Mart is evidence-based and it is better, especially based on GINA 2025. There's still a lot to be done, but I think it's very doable. And I think, again, we need to continue to assess and educate our patients regularly. And then these are some additional resources. GINA 2025 is out there for everyone to embrace. I think it's a little less than 300 pages. Don't let that intimidate you. It's pretty easy to get through. And then there's some additional sites that have good information for asthma. So thank you all for letting me come and talk. And I'm hanging around for questions. Yes.
Thank you, Dr. Hogan. It was a very engaging and wonderful presentation. Dr. Burney.
I actually have 2 questions. The first one is, do you insist that your patients use spacers?
So actually, studies have shown that in 12 and up, they are actually able to appropriately give the medications. So no, I don't insist on spacers for 12 and up if I get face-to-face time with them and they're able to demonstrate correctly. The most important thing is, what do you do with your tongue? And if you put the inhaler straight in your mouth and close your lips around it, your tongue is sitting right there. I don't think you can see that. Anyway, your tongue is sitting right there, and a lot of the medicine goes on your tongue instead of in your lungs. So what I tell patients who are not using a spacer is they have to tuck their tongue under the lip of the inhaler in order to get it out of the way so that they can get more medicine into their lungs. I think the older and older patients get with asthma, they probably should have spacers. And it may very well be that they're going to need to have the one with a mask as they get more and older because of the ability to coordinate sucking it in and holding it. So I think it's very individualized. I can tell you in my lifetime, though, when I've needed to take some medication, I've always gotten a spacer because it's easier. So, but no, not everyone has to have a spacer. And by the way, you can go on Amazon and get a spacer for $17.
The reason I ask is the majority of the adults that I see that use inhalers acknowledge that the stuff tastes bad, which to me means they're not inhaling as much as they should. And I'm struck by all of the photos I've seen, including your slides, where there are adults and I didn't see a single spacer. And so I was just curious whether your approach is to insist that people use spacers to optimize the delivery of the drugs.
So in an ideal world, I would give probably everyone a spacer. But in an ideal world, the first thing they lose after or hopefully before they've lost the inhaler is the spacer. So I think they are very useful tools. When they don't use a spacer, I make sure each time I see them that I educate them on their technique and make sure that they are using it correctly.
The other question that I had was, do you see or is there evidence that airways remodel as a consequence of constant or recurrent inflammation? And do they develop into fixed airways that no longer bronchodilate?
That could have been my next 4 slides. The absolute answer is yes. Long-standing inflammation, we do see scarring, we do see loss of lung function. Now, if we took all lungs over a lifetime, everybody loses lung volume over time, no matter what. It's part of the aging process, but we do really accelerate that loss of lung function if we have untreated asthma. And there is a point where it does become no longer reversible. So you're absolutely correct. There are consequences of not appropriately treating asthma in the long run.
Spencer.
Hey, yeah, thanks. That was a great talk. I had one quick question on, recently there was a study looking at Fasenra for acute exacerbations of asthma with good outcomes compared to oral prednisone, and then Fasenra with oral prednisone, and whether or not you think biologics in the acute setting are going to be the future of asthma exacerbations and early mild or moderate asthma?
So, as you all know, Fasenra is an anti-IL-5, so it addresses the eosinophils that are in the airway. In general, I don't. And then let's address biologics. Biologics run about $35,000 a year, and most insurance will give us some portion of that, and they take about 3 days of nonstop approval. So I don't think that they will be available for everyone. I don't think that ultimately they're going to work fast enough for people to have the immediate bronchodilation effect that they need to have. I think it can turn off an asthma attack. I mean, it chases away the eosinophils within 24 hours. So it might be able to take the place of the oral steroids, but I don't think that it will replace our need for bronchodilation in the immediate asthma exacerbation. And I don't think in a real world that the majority of patients are going to have access to biologics for many, many years unless we change our healthcare system and priorities.
Great. Thank you so much, Dr. Hogan.